Good morning, everybody. We are just getting started as usual. Thanks for joining us. And as always, we'll give it a second to get everybody into the webinar. We will, of course, be offering continuing medical education. And as usual, the link will go out to this. And as always, we'll send out a follow-up email with the links to the video and as well as links to all the related resources coming from today's Grand Rounds. I want to start, before we start with our regular updates with Dr. Huja, I'll turn over to Dr. Harrington, who's going to introduce our Master Clinician Award for this year.
So thank you, Errol, and once again to all our virtual attendees, thanks for joining us here in Medical Grand Rounds. It's really a privilege this year to be able to announce the 2019 Master Clinician Award. You may recall over the years in our teaching, annual awarding of teaching awards, we have named master teachers. With a lot of discussion amongst the department leadership, we felt that one of the things we needed to do, in addition to our yearly awarding of the Hewlett Award, which is really a lifetime achievement award, we thought it would be important within the department to really recognize our colleagues who are truly master clinicians. On this side, you'll see some of the things that some of the attributes that the selection committee was charged with. But I'll call your attention as you read through this to the bottom line. What we really want to acknowledge is what we all use the phrase, a doctor's doctor. Who is the doctor that you call when you have a question? Who is the doctor that you refer your family and friends to? Who would you go see yourself for this particular field of expertise? This is really an award to try to acknowledge somebody who is exceptional at clinical medicine. You can see that the committee included a number of exceptional clinicians, people who could really recognize the excellence that we're trying to acknowledge here. Go to the next one, Talia. And so it's really a privilege, particularly not just as the chair, but as a fellow cardiologist, for me to acknowledge and to thank the 2019 Master Clinician Awardee, Professor Randy Vagelos, from the Division of Cardiovascular Medicine. Randy is just an absolute superb clinical cardiologist. His skills range from taking care of patients with acute coronary disease through patients with advanced heart failure. He has been the director of the cardiac intensive care unit for many years, and his clinical skills, his education skills, and his commitment to both clinical medicine and teaching are legendary. So, Randy, I'll turn it over to you if you'd like to say a few words, and congratulations again.
Thank you so much, Dr. Harrington, and the rest of the committee. First, thank you for picking such a youthful picture. Yeah. And then, most importantly, I'd like to thank the training I've had here at Stanford. A number of individuals are still here and very active. Mike Fowler, Ingela Schnicker, John Schroeder, who helped start me on my way in cardiology. And then I think really acknowledge the community of true world experts here at Stanford in cardiology, cardiovascular surgery, and throughout medicine. I think for establishing and continuing a sense of fraternity, academic and clinical, that allows, I think, each of us to bring really the best care to our patients. And I think teach that approach to the students that come through. So thank you so much for acknowledging that.
Well, Randy, thank you for everything you've done over the years. And I know you, despite that youthful picture, we know you have a lot of years left. So, so thanks for everything that you do. Errol, I'll turn it back to you.
Dr. Vagelos, I just want to say congratulations. I've been able to see how amazing you are for many, many years. So awesome to have you win this award. We'll turn it over to Dr. Huja for our usual updates. Dr. Huja, thank you so much for always providing updates every week.
Thank you, and congratulations again, Randy. Very well deserved. Good morning, everyone. Just wanted to share our updates, and I'll actually focus on one aspect of this presentation in a little more detail. So starting with the overall numbers across the country, I think we are a little relieved to see that the numbers are starting to decrease, and hopefully we'll continue to see that trend. As I mentioned last week, there was a concern about a backlog of the cases through the CalReady system, and it looks like that is being resolved, and that the numbers that we're seeing are all caught up. So as I reflect the inpatient numbers here, this downward decrease is legitimate. And fortunately, the ICU numbers, although slightly higher, are not much higher. So we are seeing an overall decrease in both our daily census and the trend. So the peak that we saw back in July has definitely almost been halved. So today we had 25 COVID patients. Yesterday there were even less. Of those 25, 9 are in the ICU and 3 are intubated. If we look at the cumulative data from March 1st through August 16th, there have been a total of 344. Our ICU rates remain close to 20% or less. Females are slightly higher, and remember, this does include the pregnant women that have also been admitted to our service. The age demographic breakdown is still about the same, slightly larger in this particular age group. And I wanted to talk just for a second about the deaths. Now, our overall death rate has been 5% or less. So again, lower than, the global death rates. And we'll hear more about that from Dr. Barry today. When we pulled this data, we looked at a few things, both the STAR database, we worked with our quality folks at SHC, and we did some manual chart reviews. And these 19 deaths reflect patients who either died in the hospital or within 30 days after discharge, but had a diagnosis of COVID on their incident admission prior to that discharge. The numbers are almost balanced between male and female. And here you can see the age range and the median age of 72 years. The interquartile range here, and I thought it might be helpful to look at it as a visual. So here's a graph depicting both the total number of deaths and then the breakdown by age group. And the N is overall low, so I think we need more time for our institution to see any definitive trends, but at least we're not seeing deaths in young patients. But still, we are seeing deaths in patients that are in the 40 to 60 age group. So definitely more work to be done on this particular disease. I wanted to thank our data group. This is the county data, and then I'll turn it back over to you. Thank you.
Dr. Hujra, thank you again so much for continuing to provide updates for us every week. Before we talk about this week's presenter, I'd also like to just let you know next week we'll be talking about COVID-19 effects in the GI tract, hepatology, as well as the effects alcohol may be playing as well for some of our patients. That'll be led by Drs. Paul Kuo and Rina Mathi, Donna Sakarian. So looking forward to having that presentation next week. So this week we have another great presentation, Dr. Michele Barry. Dr. Michele Barry is a professor of medicine in the primary care and population health division. She's a senior fellow for the Stanford Woods Institute for Environment, professor by courtesy of Psychiatry and Behavioral Sciences. She's the director of the Center for Innovation in Global Health here at Stanford, and also the Senior Dean of Global Health at Stanford University. I could, Dr. Barry, literally spend a long time talking about all the things you have done and do, okay? I saw the thumbs down, I won't do that, but I will just say it's no surprise that your name keeps coming up when it comes to addressing various topics since we've gotten to this time throughout the year. So thank you for coming back to give us another Grand Rounds presentation talking about the gendered lens and COVID-19. And really thank you always for being such a great person for me to reach out to for advice on various things since really for all these years. So thank you so much for joining us today, and I'll turn it over to you.
Thank you, Errol.
I'm going to stop sharing my slides. We can let you start sharing yours. And looks like your internet's working great. Dr. Barry went into campus this morning and learned that everything is shut down. So hopefully a lot of people aren't having trouble getting on today, but a lot of the power shut down on various parts of campus. So she ran back home. Looks like the internet's working well so far, and hopefully it continues to do so.
Yeah, I have an unstable internet in the hills. So first of all, congratulations, Randy. And I'm really sorry that fire has become the new normal, because this is not going to help COVID-19. But what I'd like to spend the next 30 minutes or so is to talk about what has become of interest to me, and that is looking at the COVID-19 pandemic through a gendered lens. And I hope to convince you that it's really important to look through a gendered lens, that COVID-19 has affected women, men, and non-binary people differently, and that these pandemics create inequalities for women and girls and heighten the discrimination of other marginalized groups. And to me, it becomes really important to look at disaggregated data. And when you do, very different variables have significant impacts. Now, we know quite well that the older age group has a higher morbidity. We know that our Black and Latino populations have a higher morbidity and mortality. and that comorbid status plays a role. But I'd like to talk to you a little bit about how both gender and sex play a role in mortality and impact. Now, when I started to look at this, I was absolutely appalled about how little gender reporting is. And this is a report card done by the Harvard Science Lab. And you can see that across the United States, and for a long time, CDC did not register gender data. And you can see we do pretty well, but there are some states that are not even looking at gender and race. And you can, surprisingly, some of the red states are doing a good job. There is a group in University College London called the Global Health 50/50 COVID Data Tracker, who have done a fabulous job on collecting data since March. And again, this is data as reported by national governments, and it reflects cases and deaths only when sex disaggregated data is published by governments. So keep that with a grain of salt, because the US has not been reporting that well. But when you look at their data, and for me, a lot of clinical questions came up. And the first is, are men more at risk of COVID-19 infection? And the answer to that is globally, there is almost an equal number of infected cases against men and women. Are men more at risk of death from COVID-19? And the answer to that is yes. And in nearly every country, the majority of COVID-19 deaths are men. And men are consistently dying at a higher rate than women. And if you look at the COVID deaths across 4 continents, you can see Mexico, China, Italy, and Australia all have higher death rates. And this is thanks to Olivia Page, who helps me update this data as of August 7th. And is again, with the help of the Global 50/50. But this is a striking trend. And when you look at the United States, we have a slightly increased data. And again, CDC just recently collected gender data, so we don't have the full picture. And I thought it'd be interesting to look at California, the state that we're in, and you can see the differences in COVID deaths among men and women. Again, strikingly high. I had asked Nigam Shah to pull the Stanford healthcare data, but I think you just heard about that from Neera. The early data is, the early data was that even though we have equal amount of male and female testing and positivity, and again, these are really small numbers, there was a trend that there were more men than women dying. And it'll be interesting as our numbers get higher to see where that trend goes. Certainly in Santa Clara, it's again a higher percentage of male deaths. And when you look around the world, even in LMICs, and when I use the word LMIC, I mean low middle income countries, as well as high income countries, you can see that many of them are greater than 50%. So why is this? And this became very intriguing. And this is what explains the difference in mortality rates among men and women. Now I'm going to give you a lot of hypotheses, and I expect a very interesting Q&A. But let me put together what I've thought about as some of these differences and pulled some of the literature for you to think about. And the first way I'd like you to think about it is the gendered social determinants, people that really associate themselves as women or men. And this is what might be some hypotheses why men die more. Well, the exposure to infection through work, there are more male essential workers, and I'll show you some of that data. There is more healthcare seeking behavior differences. Men are slower to seek care and might present at a more severe presentation. And then the comorbidities of chronic diseases, and particularly the chronic diseases that impact COVID-19, are at increased rate in men. And then I want to talk a little bit about preventative measures and risky behaviors. It's clear, and there's some, I gave you some of the references, and I'll be glad to share these slides, that there's lower levels of hand washing, social distancing, and wearing of face masks by men, and higher levels of smoking and alcohol use amongst men, all of which obviously might impact COVID-19. And just to prove that there are more essential workers, interestingly enough, although we've heard a lot about the meatpacking industry, which has a predominant amount of males, you can see transportation, warehouse and delivery, wastewater, and critical manufacturing, which are the highest levels of inequity in actually getting COVID-19, is a higher percentage of men. And when you look at the comorbid diseases that impact men more, men have more ischemic heart disease, stroke, and COPD. And this all comes from the global 50-50 COVID-19 data tracking. So let me talk to you about the sex and biologic differences that might really play out in this story. One, I found this very interesting. There were a couple of papers on this, that the ACE2 receptor activity level in lungs is higher in men. And I also found a paper that showed that testosterone actually upregulates the ACE2 receptor level in men. And I actually had a discussion with Mark Davis because I pulled some of his work on the immune response differences as seen in flu vaccine. There's no question when you give the flu vaccine that there's a more robust response, not just in antibodies, but in all kinds of signatures, that women respond more robustly to flu vaccine. And Mark also went further, and his laboratory looked at the levels of testosterone and showed that the higher testosterone also muted the flu vaccine response. So clearly, estrogen and testosterone play a role. And this might make you think, well, what about menopausal women? And I have a slide on that also. The X chromosome, and since those of us who are XX have 2 of these, have a higher density of immune-related diseases. And as we all know, autoimmune diseases are much higher in women. And so that brings me to some of the SARS challenges in mice, which I found fascinating. And this was a SARS-CoV-1 challenge in mice, which showed that male mice are highly susceptible to SARS-CoV-1 and had a higher mortality. And after SARS-CoV-1 challenge, the level of these cytokines and chemokines remained elevated or even increased in the lungs of male mice compared to women. And then, I don't know how they did this, but when they oophorectomized the female mice, they were as susceptible as males to SARS-CoV-1. Again, showing that there is something to do with the hormonal. And then when you look at SARS-CoV-1 in the Hong Kong outbreak with humans, you could see that the case fatality, again, was strikingly higher in males. And for males compared to female, the relative mortality risk was higher. And when you look at the Middle East respiratory syndrome, or MERS-CoV, these are even more striking differences. And I have a hypothesis about why. This was more common in men. Remember, we have equal in COVID-19. But I think that has to do with the fact that the cycle was in dromedaries or camels, and it's mostly men that take care of the camels. But when you looked at men and females, there was still a higher fatality rate among men. So the question is this occupational exposure? And here I wanted to talk a little bit about menopause and COVID-19. And I know Marcia Stefanik is listening. And we had a discussion about this. I could not find a lot of papers on that. Surprise, surprise. I did find one preprint, which actually I thought was fascinating, and looked at levels of estradiol correlating with more severe disease in menopause. That actually the higher level of your estradiol, even when you were age corrected, you had a less morbid disease. And for those of you who are interested, there is now a randomized control of transdermal estrogen in the outpatient setting with mild COVID-19 to study the rates of hospitalization, transfer to the ICU, intubation, and death. And in case any of you want to sign up, the study location is at Stony Brook, and they're currently recruiting. And then I looked at children as well, and the multi-system inflammatory syndrome, which we had a wonderful Graham Rounds about. You can see that here again, even though it's a different distribution of men and women, there's 62% males that are coming down with the multi-system inflammatory syndrome in the United States. And I found Dr. Landry's presentation last Graham Rounds, and I tried to pull it back into here because I asked him a somewhat provocative question, which I think he misinterpreted. But this, as you remember, for those of you who weren't at Graham Rounds, it was a national clinical trial in the UK, which aimed to identify treatments that might be beneficial for people hospitalized with suspected or confirmed COVID-19. And I noticed that in all of his hydroxychloroquine study, and all the studies that he showed, that it was about 62% of participants were male. And when I asked him the question about why that was, I think he thought that I was saying that he was ignoring the women, but I wasn't. I wanted him to actually comment on the fact that that reflected the proportion of patients with severe disease. And that is what he said, that that was the ratio of people coming into that randomized evaluation study. So now I'd like to talk a little bit about the impact of COVID-19 on women and girls. And just to remind you, is that women make up 70% of the health and social workforce worldwide. And it's not so surprising when you look at who is getting sick in healthcare workers around the world. It's a striking amount of women, and from 64% to 73%. Now you might say, what are some of the reasons of that? Are they not getting PPI? And at the beginning of COVID-19, at least in the US, there was quite an uproar by the nursing profession, which is predominantly women, that they were not getting equivalent masks or N95 masks. And I'm sure that that did not happen at Stanford. But in many of the hospitals, I know at Kaiser, there was quite a brouhaha about the fact that there was inequity. And then for the rest of the world, one can look at the population, proportion of population that's able to access some of the COVID-19 information by sex. And you can see that in some of the developing countries, they didn't receive information. It was confusing or contradictory for women. It was clear, but it came too late for them to prepare. And then a very small proportion helped them prepare. So access to information, women globally may be disadvantaged in access to critical COVID-19 information due to lower educational levels, lack of access to technology, and societal limitations. And I'll push your eyes a little bit to the gray box, that there is still a dramatic internet user gender gap worldwide, where men remain 20% more likely to be online than women. And in the developing, that's in the US and high income, and in the developing world, that actually increases to 52% in the world's least developed countries. Then I want to spend a few seconds on the mental health impact. And this is, for those of you who don't know Kaiser Family Foundation, I find them excellent pollers. In fact, a very good friend of mine is the head of the polling. And this was a dramatic study that indicated that women were far more likely to worry about health and economic effects on their families due to COVID-19. And this came out very strongly in frontline female healthcare workers in China. And there's a nice study looking at that the psychological burden was particularly prevalent amongst women. And then this is again from the US and the Kaiser Family Foundation poll, which showed that there's still a dramatic difference between men and women with mental health stress. And particularly parents of children under the 18, females have more of a mental health impact. I want to take a step back to the next subject. I mean, every time I turned the page looking at this gender difference, I found a new area to talk about. And this is about gender-based violence. And the UN Population Fund estimated that 6 months of lockdown could result in additional 31 million cases of gender-based violence. And when I pulled papers, particularly in LMICs, I mean, one can imagine when you're shuttered in that there's quite a lot of stress, that there's intimate partner violence, there can be sexual abuse and exploitation. And then I'm going to spend a little bit time later talking about how there's an increased stalking online. So this showing that there's an increased risk of gender-based violence in the context of public health emergencies. Now I want to step and talk about the economic challenges for women globally. Many of you know that domestic work and unpaid work is higher in the, for women, that 1 in 10 women around the world globally have been forced to take unpaid leave, and 740 million globally work in the informal economy, making them much more vulnerable to economic downturn. And then I thought I'd look at the US, and in the US, the economic downturn due to COVID-19 has been particularly devastating for women. Women accounted for 55% of the 22 million jobs lost in March and April, and Black and Latinx women have experienced the most severe job loss due to COVID-19 in the United States. So here again, we have quite a disparity between men and women. The burden of caregiving, particularly for the elders, falls mostly to women, particularly around the world, and childcare, including homeschooling. Now, the good news is that I pulled a study where it showed that men are increasing their time with homeschooling, but women on average spend 4.1 hours per day on unpaid care and domestic work, compared to 1.7 hours per day by men. And this comes from the World Economic Forum. So you can imagine that there's an increased burden on women or working women and caregivers working from home. The impact on education. Globally, girls may be excluded from online education and required, even in the US, to take on more caregiving roles in domestic work. And online learning modalities, or Zoom, or being in front of a computer, can introduce new or increased risks of various forms of online exploitation, and particularly for women. And this is a slide that is really plays to me and resonated to me, because I have a daughter in her 3rd trimester who's and she's being seen at one of our competitors, Mass General, and it really has been seen literally twice in the 3 trimesters that she's in. And that's because lockdowns and supply chain disruptions have reallocated resources and ability for maternal health to women and girls to have antenatal and postnatal care. It's also impacted such services as being able to get your IUD or sexual and reproductive health contraceptives. There's been a diminishment, and just like we had the toilet paper problem, we have a lack of delivery of menstrual products. There's diminished access, besides our US government, but there's been diminished access to safe abortion and post-abortion care, and mental health access, as I alluded to earlier, mental health stress, but it's harder to access mental health. Although there is Zoom ability to see therapists, there's still a lack of ability to access that. And then I want to spend a little bit of time talking about the LGBTQX populations and why they may be more impacted. And again, this is a gendered look. This is not just about women or men, but also on LGBTQ. And nearly 1 in 10 LGBTQ people are unemployed and are more likely to live in poverty than straight or cisgender people. They experience discrimination and lack of cultural competence while seeking healthcare. And I think Leslie Subak and the group at Stanford have done a great job in creating a safe place for them to get care. But there's still a delay in accessing globally as well as worldwide. And in the US, 17% have no health insurance. There's also a high risk of HIV and tobacco use. I thought it was interesting, and I pulled this, which just came out a couple of days ago, in the Journal of General Internal Medicine, that our PRIDE group, or the Stanford PRIDE cohort of about a little over 2,200 people, there was a survey of mental health, and there was a dramatic impact on the mental health of LGBTQ populations. And this is, so why did a tropical disease doctor get interested in this? And I'll give you a little bit about why. And this had to do with a phone call that I got from Jocelyn Clark at The Lancet, because she knew I was running a women's leadership in global health, and she's on my board. And she said, basically, Michele, do you know that we're not getting any submissions from women? It's just dramatically dropped. So I had the pleasure of calling Brooke Gapster and asking if she would do the work, looking at what is actually happening with women publishing from female scientists in The Lancet. And we found that the number of male submissions is growing far faster than female submissions during COVID-19. We had some hypothesis that it was maybe childcare and homeschooling, lack of protected time, domestic work. And then I had no idea, but in the United States and the UK, there's single mothers. It's the percentage of female-headed single parent households are actually 80% the single moms in the US and 86% single moms in the UK. And when we looked at The Lancet for Jocelyn, we showed a gender distribution that was grossly different for men and women, whether it be a research article or a commentary or a public health article. And when we looked at the pre-COVID time, it was about a 22 to 24, I think it was 24% drop in productivity. So this was printed in Lancet recently, and I give a lot of credit to Brooke. And then for Dr. Harrington and Ken Mahaffey, this is an interesting paper. Again, it's a preprint, so we'll have to wait. But this is kind of just gross numbers. It turns out that more than 2/3 of investigators leading COVID-19 clinical trials are men. And this disparity indicates a lack of women leadership in international clinical trials. And I tried to find pre-COVID times, and Bob, it would be great, or Ken, for you to comment in the Q&A. I'm sure this discrepancy exists, but I thought this was grossly abnormal to have 72% to 28%, and reflects imbalances in women's access to research activities and funding during health emergencies. So I thought that was interesting. And then when we look at women leadership during COVID-19, 10% of the US coronavirus tasks are women, 20% of the WHO Emergency Committee on COVID-19 are women, and 16% of that first group that went in from WHO, where they called experts, were women. So you can see that during the COVID-19 women leadership, it's really not there. Yet, when you look at who's done successfully, brought their countries to zero or low percentages, women who are heads of state and government have been the most successful. And you might hypothesize why, but it's also been described as that they have a more collective approach than individual approach. They're more collaborative than competitive, and they have unified messaging and leadership. And I would say all of those three bullets are lacking in our current administration. And women's leadership, if you look at the statistics, the heads of states are really small as heads of government, and women ministers, even women ministers of health, are about 24%. And the majority of parliamentary seats are held by men. And then I looked in, and this has been really the impetus for starting the Global Women's Leadership Program. It turns out only 25% of female representation or leaders within global health, despite the fact that the majority of women studying it or in the front lines are women. And in my colleagues in low and middle income countries, and this is where it started for me when I was in Nairobi looking at a MEPI meeting and saw that there was absolutely a pathetic amount of female global health leaders with all the deans around Africa. So there's a great discrepancy there. And so this, this really was an impetus for us to start Women Lift Health. And thanks to Bill and Melinda, who have very generously given us many millions of dollars to start Women Lift Health. And this is a vision of a world where diverse, accomplished leaders collectively transform global health outcomes. And really what we're doing is not about fixing the woman, but actually bringing men along, because we can't do anything unless we engage men, and really try to catalyze systemic change to achieve gender equality in leadership. And what we're trying to do is to develop culturally sensitive leadership training programs with geo-hubs around the world where countries have ownership of their geo-hubs, but we're helping to develop the curriculum. We're giving senior women mentors, personal coaches, and digital in-person curriculum for 1-year training, and then continue that training until we skill build 3,500 women in 10 years into CEO or leadership programs, with ultimately forming a robust network of women. So then I would like to conclude and open to Q&A about what I think, and I'd be interested in hearing what other people think about recommendations for a gender lens approach to COVID-19. And one is to ensure that policies and interventions around COVID-19 are responsive and inclusive of everyone's needs, and that we should prevent diversion of resources from sexual and reproductive health access programs, that we need to incorporate voices of women and women leadership on the front lines of the response. And we need to prioritize, and I can't say enough about this, the collection of accurate sex disaggregated data and research efforts. And this is not only for women, but also for men. And lastly, I think we need to develop safety net infrastructures for women in the community and in the academy. Now, I know that I probably have, there are no definite answers. There are a lot of questions. This was a very interesting grand rounds for me to put together. I continue to want to look in this area, but what I'd like to do is open it to Q&A and also sharing of experiences that you have had. I've also been working on the the Faculty Women's Forum, where we're continuing to hear tremendous complaints about inequities for our faculty at Stanford. We've just put out a survey, which I hope all the women in the that have gotten this survey, because we're going to Provost, to Persis, as well as to MTL, to try to really be able to financially and emotionally support women at Stanford. Thank you very much.
Dr. Barry, thank you for that. That was an extremely comprehensive look in the gender lens through different angles. So that's really fantastic. I want to first, Dr. Harrington had a comment, particularly around the research aspect of this. And Dr. Harrington, I wanted to turn over to you to make any comments or questions.
Well, first off, Michelle, thank you. That was a fantastic overview of the gender-related issues in COVID. And I wanted to respond to your comment about clinical trials leadership. You're absolutely right. It's not just in COVID, but clinical trials, particularly the area I know best, cardiovascular medicine, the majority of the trials are led by men. But an interesting paper appeared recently in the heart failure literature that if you look at clinical trial reports, when women led the trial and when there were more women authors on the paper, the participants in the clinical trial were more diverse. So having women leadership of the trials has more benefits, it looks like, than just equity, that the women actually do a better job of enrolling a more diverse patient population. So that's important. Second, I typed in the chat box that NHLBI is just starting to announce its first rounds of clinical trials related to COVID, as we now are seeing more and more cardiac complications of the disease. And the first trial that'll be launched in the next week or two is led by a woman, Judy Hockman at NYU. So the first NHLBI trial in this area will be led by a woman.
So that's great, Bob. But it's been very interesting when you look at the business, you know, again, because I had to convince Bill and Melinda that we needed to do this, but when you look at the business industry and boards, it's clear that when there are more women on boards for business in the Forbes, you know, top 500, they have better outcomes with profit. And that led Newsom recently to say that 25% of all boards in California had to have women. And when you look at health, and this is one of the things we had to convince also the Gates Foundation, because Bill asked about ROI, which for me, I didn't know what it meant, but it's return on investment. We had to prove that having women in health settings actually can improve health outcomes. And we will be, that's part of our metrics that we'll be looking over in the next 10 years. But that's great about the NHLBI. That's great.
Great. Thanks so much. Ken, Dr. Mahaffey, you had a comment?
Hi, Ken.
Yeah, quick. Hey, hi, Michelle. Michelle, that was a terrific grand rounds. Thanks for all the thought you put into it and the great presentation. I'll give you just a quick update. I was able to do a very informal and quick analyses. We've had 64 clinical trials proposed for COVID research at Stanford. 28 of those 64 trials had a woman as the principal investigator or co-principal investigator. So at least in our local environment, we're seeing a much better representation of women. But obviously, since we have a global and national force here, we need to do more to promote this externally, as you've nicely articulated. Thanks.
I applaud you.
Great. Thanks so much, Ken, for the comment as well. I have a number of comments, and for our panelists, if any of you want to ask the comments out loud, you're welcome to. So we have a few coming through the chat because they can't put questions in through the Q&A function. And I have quite a few questions coming up on the Q&A as well. I'll get through a couple of the ones on the Q&A. Dr. Barry, any data on the male mice status post orchiectomy were less susceptible? Any more info on that?
I don't think those male scientists wanted to do orchiectomies. So I did not find that. No, this isn't oophorectomized. Well, that's a very good point. Why didn't they do orchiectomies?
It's a good one. Speaking of that similar question, so to be clear,
well, can I make another, because I give another talk on male-female in science. When you look at the mice that are used in most studies, they're all XY mice. They're all male mice because in most studies with mice, they don't want to have to deal with menstruation. So that's been a big, Londa Schleibinger, I think is her name, has looked at that. And the NIH has started to look at that. But if you look at what most of the mice studies are, they're mostly male mice.
Gotcha. So to be clear, we are not sure if the lack of mutagenicity is due to elevated T or decreased estrogen.
So I asked Mark Davis about that, and it's definitely not clear.
Okay. Speaking of estrogen, any data you ran into on estrogen and the elevated clot risk in COVID?
So I did not, that's a really good question. I did not look at the rates of pulmonary emboli. We all know that there's an increased risk of clotting during COVID-19. I'm curious, I don't know if Angela Rogers or any of the ICU people are on, whether they're, and again, I think clinicians, and this goes to Randy, I think clinicians are often our sentinel people, which push us into looking for research. And I'm curious as to if any of the ICU docs are seeing that, but I did not see that in the literature. But again, you know, I may have missed it.
No problem.
Is there anyone that wants to comment on that?
Hi, this is Neera Ahuja. I can just comment that at Stanford, more males have had DVTs or PEs related to COVID than females. But, you know, our N is smaller than other places in the country, but that's what we've seen.
But, you know, Neera, that may be because there are more males winding up in the ICU and having more severe disease. So there are obviously some confounding issues. You know, again, I think someone needs to look at the study.
Great, thanks so much. Any comment on vaccines and gender? How are clinical trials considering these differences?
I think they have to start. I'm sure they're considering it, but I would not be surprised since when I talked to Mark also, because again, this is not my area of vaccines and antibiotics. I'm not an immunologist. He said that in general, not only with flu vaccines, but with pretty much all vaccines, women have a more robust immunologic response. So I'm hoping that during these studies, again, I can't promise that'll happen, but I'm hoping that during these studies, there'll be male and female looking at that gender disaggregated data.
Okay, great. So the question here, actually, well, Hector asked a little bit, we've talked about before, but Hector Bonilla asks, Michele, how are we doing at Stanford with women on research COVID-19 representation? Again, Neera just mentioned some of that data. Anything else to comment on?
Well, I think Ken actually answered
yeah.
that also, that we're doing pretty well. And even in, Ken, you want to comment on the representation? I know UPI's on your board of accepting studies. I'm pretty sure that there's an equal representation of women and men.
Yeah, absolutely. When we put together the COVID clinical research review panel for the School of Medicine under Ruth O'Hara's leadership, we wanted to have representation across multiple domains, including gender, including methodological domains, and also clinical interest areas. And I think we did put together a panel that represented that, and we had people on it such as Upi, Neera Raju, Angela Rogers, and many others.
Right. Marcia, Dr. Stefanik asks, I know higher smoking rates in men is often offered as an explanation for the higher male deaths. But is there actually any evidence to support this? Are male smokers dying at higher rates?
So Marcia, good question as always. I don't think it's been looked at in the US. In China, there was, but I take that with a grain of salt because remember, male smokers are going to have more COPD, more ischemic heart disease. So there's going to be confounding issues, and not just due to the smoking. Although we all worry about that with the PM 2.5, that we're going to, now that wildfires have become the new normal, in California, I really worry about these wildfires and whether we're going to start to see a surge in more COVID-19 mortality or even infection.
Ronald, Dr. Gibbs asks, what are your insights about outcomes of COVID-19 in pregnancy? Data are mixed, but in late June, CDC reported increased hospitalizations and ICU admissions among pregnant women. Yet in the CDC study, there was a much missing data.
Believe me, Dr. Gibbs, I am looking at this incredibly hard because, as I said, I have a very pregnant daughter. And I do agree there's many missing data. And, you know, the defunding of CDC, and don't even get me starting about the defunding of WHO, has really hampered our ability to look at data. And now with the shunting of data to the White House and not CDC, it's become even more suspect as to whether we'll get the good disaggregated data. And lastly, since I have a lot of colleagues in CDC who are very frustrated, when I asked them about the vaccine rollout and whether they'll be looking at allocation and gender allocation and et cetera, and Latinx and Black, they have been told that the rollout will all be handled by the White House. So please, everybody vote November 3rd. 76 more days, 75 more days.
Great. keep it going. Michele, we have so many questions coming up. I'm going to try to get to as many as possible. And for the ones we don't get to, I'll perhaps maybe send them out to you if you'd like to answer later. But the next question comes from Laura. Thanks for a great talk. Supporting women in COVID time is such a complex issue. I've heard a wide range of suggestions around this. Is there anyone working to lead in this field by making a minimum list of options to support women faculty, childcare supplement, flexible schedule, alternate work days, stuff like that?
Is that Laura Roberts? Because, well, Laura, whoever Laura is, thank you for that question. And yes, the Faculty Women's Forum is working very hard on this. And to Percis's and Mark's benefit, whatever, they are listening and they're trying. I can maybe, off the top of my head, I can't tell you what they're giving money and childcare support, and there's a whole list of things that they're doing. And I can, Errol, I can try to send you that later. But the person actually to talk to who's leading this is Carol Muller, M-U-E-L-L-E-R, in the Faculty Women's Forum, and Mary Hahn, in Chief of Surgery, is the head of our board.
Okay, great. I'm going to jump over to a question from Kathy Garzio here in the chat function. Earlier this year, Stanford and other universities announced a tenure clock pause of 1 year to help faculty impacted by the pandemic. However, I've also read that this is inadequate response, and the whole concept of helping women and men faculty achieve tenure needs to be reconstructed. Do you have a point of view about this? Will this be addressed in the survey you recently sent out to women faculty?
Thank you, Kathy. And I know you've been a big supporter of equity. So here's the deal. You know, even though there's this 1 year tenure clock stop, we've gotten a lot of feedback from mostly the other side of the university. No, I shouldn't say other side, the HNS, that the women are actually being told not to take that 1 year, that it's going to actually hurt them when they come up, that they won't be as productive, and that they're failing their laboratories or failing their teaching responsibilities, and that will be a burden on other people. So we're trying to address that. I think that's even more important than restructuring and giving another year of tenure relief. And again, I don't only think this is for women. And I try to, when I put the title of this is about a gendered lens, because I think this can impact men as well as women.
Great. Marcia asked another question that's been voted up here. Have you found data on testing and screening to suggest that women may get more tests when they are readily available, but men may get more tests when they are limited, therefore a special resource?
That's a Stefanik nuanced question. Clearly, women do get more screening. They come in more to get testing. They avail themselves of health care. But I haven't seen anything that when it becomes special, more men show up.
Gotcha.
But that would be an interesting question to look at.
Gotcha. The Laura was Laura Ludanowski, hope I pronounced that right. I want to jump to a question by Dr. Wynn, Linda Wynn.
Laura is one of my mentees from Women Left. I love it.
Great. But Linda's been, Dr. Wynn's been a huge proponent in women's really supporting the efforts on this gendered lens, much of what you've been talking about. She asked, given the impact of COVID on productivity and other metrics used for promotion, what are plans in place to support those impacted negatively? Extending the clock seems to delay promotion for women who are disproportionately affected. So similar to,
I think I tried to answer that.
Yeah, Kathy's question as well. So anything else to comment there? I think you.
No. Okay. I just, Linda, I would just say, I really hope that, you know, we get such poor response on our surveys. The more data that we can put together, the more ammunition we have to go to Persis and MTL.
Great. An anonymous question here. How do you think we can include Indigenous women in leadership roles within medicine during the pandemic and after?
Oh, that's a fabulous question. You know, we have such a small, well, let me just say that is no question. And we have a group, our center has just sent a team over to work at Pine Ridge, and Yuen Wang has gone over to the Navajo Nation. There is no question that Indigenous women are being impacted, as well as our Native American population. They are being impacted much higher than the rest of our country, or equivalent to some of our hot spots. What I think is interesting, I don't know if anybody read the New York Times piece, and I have to say something because it was 100 years of suffrage, but there's a wonderful section of the New York Times on suffrage, which talks about what a huge role Indigenous women played in suffrage, because they have matriarchal settings, that they actually worked with Susan B. Anthony and Stanton to actually share some of their matriarchal settings. So I suspect, and again, not my area of interest, no, it is my area of interest since I started out in Navajo Nation, but not my area of expertise, that Indigenous women do play a role, but I can't comment on that. I can say the people that we've been discussing at Pine Ridge and Navajo Nation have been women that we've been interfacing with.
Gotcha. Dr. Barry, a question from Dr. Clevis came in here on the chat earlier during your presentation. He asked, gender-based stress reporting, do we know if the reporting itself is gender influenced? That is, could it be more functional for women to report and acknowledge stress than men who are socialized to not admit it? So a higher level of reported stress could be adaptive?
Absolutely fabulous comment. I agree with that, for sure. Men have been taught not to go and talk about their mental health as much as women. There's a far higher percentage of women depressed that come up in depression, but I suspect men are just as depressed. But again, I can't comment on that because it's hard to study.
Gotcha. Dr. Tompkins, you had a question earlier in the chat. Would you like to ask that live? Or I can read it out for you.
Well, I was going to ask, just at the very beginning, Michelle, where you were talking about the gender disparities with COVID-19, but I thought there are a lot of other infectious diseases where women are less likely to have morbidity and mortality than men. At the top of my head, I couldn't think of all of them, but it just seemed to me that that's sort of a theme in infectious diseases, that women are more protected somehow than men.
So I asked Mark Davis about that also, because again, I'm not an immunologist, so I wanted to make sure I had all the facts before Grand Rounds. And he said that that's generally true, but actually women do worse in sepsis. And so they're trying to figure out now whether the cytokine response is worse in sepsis. And I'm sure we've all seen in H1N1 that pregnant women in particular did really horrifically during that epidemic. So interesting question, Lucy. And when I pushed Mark about it, he said, I don't know, there's just so much conflicting data. So.
Great. And then Dr. Barry, perhaps I'll end, we're getting close to 9 o'clock here. There may be a few more questions that I emailed to you if you'd like to address, and we can send them out to everybody with the recording of this video after. Thanks to Olivia Page for sending a lot of links to many of the questions that are answered in here as well to support your answers, Michelle. But Dr. Barry, from a public health perspective, what approaches do you think would be effective in narrowing the gender disparity and adopting preventative measures?
Could you put up my last slide? Or I have to put up my last slide. Let me see if I can even find it. Well, I think what I tried to do, of course I can't find it now. What I tried to do is, I can't say enough about that we need to have disaggregated data, that we need to look at the sex and gender. And it's not just for women, it's also for men. And if you take one thing home from my talk today, it's that this is really crucial, and not only in COVID-19, but in many other diseases.
Great. That was a great way to end it. Dr. Barry, thank you so much for everything you do in this space and many of the other spaces you are working in. Thanks for another great presentation. Again, this will be recorded, sent out to everybody, and any other things you want us to send out with that, please let us know. We'll send out any other resources or slides or whatnot. Thank you, everybody, for sticking with us throughout this time. I hope you have a great week, and we'll see you next week. Bye-bye.
Thanks, Errol.
Thank you.